Bismillahirrahmanirrahim. My name is Dr. Imran. I work as a senior registrar in orthopedic department, surgical orthopedic C ward under supervision of Dr. Shiv sir. Here we are going to present a very interesting case of pediatrics orthopedics. We had in this case, we have senior Dr. Abbas Sahib, who is also a pediatric orthopedic surgeon and working assistant professor. We also involved and discussed this case with Dr. Sikandar Hayat Sahib, who is the president of Pediatric Orthopedic Society of Pakistan and our senior supervisor of the pediatric orthopedic surgery. So we are going to discuss this case. This 10-year-old hijab presented to us with pain of the bilateral hip from last 3-4 years and limping gait. She had a pain which was increasing day by day. Gradually, pain was increasing, and now the pain was unbearable. She was able to just go a few minutes, and then the pain was severe. She was not able to walk after 10 minutes. So we done the X-rays. We analyzed the X-rays. In X-rays, we can see that it has a bilateral hip, the epiphyseal dysplasia, the patient has multiple epiphyseal dysplasia. We also done the X-rays of the knee joint that are also involved. The knee joints are also involved. So if we see the hip joints, both hip joints involved, severe involved. The patient had symptoms more on the right side, so we choose to operate the right side first. And we will then plan for the left side also after few times. So the right side, if you see to the X-ray, the head is contouring is round, but there is irregular surface of the head. There is erosion of the head. The acetabular is not developed properly. The acetabular index, if you see, the acetabular is wide, and the head is there is superior migration of the head, and there is if you see, there is a uncoverage of the head, and the greater trochanter, there is a superior migration of the greater trochanter, and there is a short neck of the femoral neck is short. So we planned about the treatment plan. So we want the proper coverage of the femoral head, and for this we planned that we should there is superior migration. So I think the planning will be more discussed by Dr. Abbas Sahib, how we done this procedure.
Thank you, Imran, for such a nice discussion on this case. Basically, the different problems we are facing over here is the first is acetabular dysplasia, which is showing that the head is not properly covered, and secondly, we are having a growth arrest on the lower median part of the capitis as well, and the overgrowth of the trochanter. So we had to address all these things. First, the coverage problem. Secondly, the overgrowth of the trochanter, which later on probably the patient has already developed abduction lurch. So with a different way, first of all, we try to cover the hip, and then we are trying to address the hip abductors as well. So for coverage, what we did, despite that we had a pre-op plan which we discussed already with Sir Sikandar Hayat, then we came per-op for the planning. So when we abducted the hip, so the coverage improved. So with this, we gained the idea that if we go for the Varus osteotomy with a bit shortening, so probably the head will come inside the acetabulum, and that will address later on the acetabular dysplasia as well. So we planned for the Varus osteotomy in this case. These are the steps of the Varus osteotomy, and which shows that the head came inside. Along with the Varus per-op, we did a bit derotation, and with the derotation, we gain the maximum length of the neck. So probably the neck shaft the length of the neck was probably addressed in this way. Then after completing our Varus osteotomy, we did the trochanteric complete epiphyseal, and hopefully it will help us later on for the coverage, the correction of the Varus angle. We did intentionally, and for now probably this was the this X-ray is showing that you step back, that the head is covered, but a little bit probably we had some uncovered area. So then for addressing that, we did carry osteotomy, and these are the steps of carry osteotomy, and followed by the carry osteotomy when we push the head, and then now you can see that the acetabular index and the coverage improved after that. So hopefully now we are waiting for this to be working. Later on, if the abductor lurch is not improving and this is not going to work, still we had some age of the patient that will be working. The growth potential will be working for us, but because we are not sure of this area of the Epiphyseal, that whether it is working or not. But if it works, then the problem of vulgus will be achieved with us. But if not, then we will, in the second stage, we will go for shift of the trochanter to address the abduction lurch. But at the moment, you can see that we are having a proper acetabulum at this time, and the head is covered, and later on with this epiphyseal disease, we will achieve vulgus of the neck as well. So the abduction lurch will improve. Thank you.